Hi, this is Dr. Sushma. Today we are going to study about the osteoradionecrosis, which is a late complication of radiation therapy, and it occurs when an irradiated area of the bone becomes devitalized. This topic under the following headings. First of all, the definition, pathophysiology, predisposing factors to osteoradionecrosis, diagnosis, and finally the management part. The literal meaning of osteoradionecrosis is the death of the bone tissues due to radiation therapy. It is defined as an area of exposed, irradiated bone tissue that fails to heal over a period of 3 months without residual or recurrent tumor, and when other causes of radionecrosis has been excluded. Osteoradionecrosis typically manifests 6 to 12 months following the radiation therapy, but it can develop anytime from months to years following the radiation therapy. The incidence is approximately 5 to 7% for the conventional radiotherapy. Osteoradionecrosis is more frequent in mandible as comparison to the maxilla because there is relatively lower vascularity in mandible. Osteoradionecrosis risk is dose dependent and increases 11 folds when the dose exceeds 66 grays. When the dose is less than 60 grays, it is unlikely to occur, and it rarely occurs if the dose is less than 50 grays. So important risk factors of clinical significance include carious teeth, periodontal disease, trauma from the dental extraction, or the ill-fitting denture. It is most commonly affecting the jawbone, particularly the mandible, because of its dense bone structure and lower blood supply compared to the other bones, as we have already discussed. The most widely accepted theory for the pathophysiology of osteoradionecrosis is triple H, which was given by Marx in 1983, and it is hypovascular, hypocellular, and hypoxic theory. This theory suggests that the radiation damages the blood vessels, leading to reduced blood flow, which is known as hypovascular. Decreased cellularity is there, which is hypocellular, and the lower oxygen level, hypoxic, in the affected bone tissue. This impairs the bone's ability to heal itself and results in necrosis. So radiation causes damage to the microvasculature of the bone, leading to chronic ischemia, which then imparts the normal bone remodeling and repair process. Regarding the predisposing factors, the combination of intrinsic and extrinsic factors that increase the risk of the developing mandibular osteoradionecrosis are radiation therapy, which is given in high dose for the longer duration of therapy, any pre-existing dental issues or invasive dental procedures like tooth extractions after the radiotherapy can trigger or worsen the osteoradionecrosis. Medically compromised patients having poorly controlled diabetes or any other autoimmune disorders, lupus erythematosus, or rheumatoid arthritis can affect overall bone health and healing. Medications, bisphosphonates, which is used to treat osteoporosis, can contribute to the medication related osteonecrosis of the jaw, and along with these, the other medications, anti-resorptive agents, which are affecting the bone metabolism, can also increase the risk of the necrosis. Along with this, the compromised tissue integrity, inadequate tissue oxygenation, smoking and alcohol consumption of the patient, any other chronic illness or nutritional deficiency, or generally the age factor or the immune status factors, they all affect the development of osteoradionecrosis, making the patient more susceptible to infection and the necrosis. Diagnosis is primarily based on the clinical examination and patient history, especially a history of radiation therapy. Along with the clinical diagnosis, imaging, X-ray, CT scans, or MRI may be used to assess the extent of bone damage and identify the areas of necrosis. One of the hallmark signs of osteoradionecrosis is the presence of exposed necrotic bone, which is visible through oral mucosa or skin. This area of exposed bone may be asymptomatic at first, and later on it becomes painful with due course of time. The bone may remain exposed for the weeks to months without showing any signs of healing. The pain is dull and aching, and it can range from the mild discomfort to severe persistent pain, and it often worsens on the condition progresses or the infection sets in. There is a soft tissue ulceration also due to soft tissue breakdown, and the ulcerated mucosa skin may be associated with the chronic non-healing wounds. Intraoral ulcers are particularly common in cases where the jawbone is affected. Swelling is localized in the region of necrosis, often due to the inflammation or secondary infection. There is foul odor, halitosis, infection, and the drainage can be there. And pathological fractures may also occur in the advanced cases where the necrotic bone becomes structurally weakened, making it more prone to pathological fractures. And this is more common in the mandible due to the weight bearing role in mastication. There may be paresthesia or numbness due to the damage of nerves. Trismus may be found in some of the cases where the muscle of the mastications or the temporomandibular joints are involved. Difficulty in eating or speaking may be found. In some cases, pieces of necrotic bone, which is known as sequestra, may become separated from the surrounding healthy bone and may eventually be extruded through the oral cavity or through the skin openings. Radiograph shows the signs of the bone destruction, which is visible as a radiolucency, sequestra, and a moth-eaten appearance. Pathological fracture may also be visible. Notani classification is used to classify the mandibular osteoradionecrosis, and it is designed to categorize the severity of the condition based on the clinical and radiographic features. Management and the treatment of osteoradionecrosis varies based on the severity of the condition and may involve a combination of conservative measures, surgical interventions, and supportive therapies. Prevention is always better than cure. Before radiation, the patient undergoing a dental evaluation to extract any teeth at risk of infection or decay. This reduces the likelihood of osteoradionecrosis developing after radiation therapy. Along with this, the patients are often advised to use fluoride trays to reduce the risk of dental caries to prevent the development of osteoradionecrosis. Also, the patients are advised to avoid invasive dental procedures like extractions in irradiated area wherever possible. If dental work is necessary, it should be done with a caution and may require prophylactic antibiotics and hyperbaric oxygen therapy. Conservative management includes the pain control by the use of analgesics and the anti-inflammatory medications to manage pain and discomfort, infection control to implement appropriate antibiotic therapy to manage and prevent the infection, and emphasize the importance of maintaining an excellent oral hygiene to prevent the complications in future. Surgical intervention includes debridement and reconstructions. Surgical removal of necrotic and infected tissues is done to promote healing and prevent the spread of the necrosis. In severe cases, reconstructive surgery may be necessary to restore oral function and appearance. Supportive therapy comprise of hyperbaric oxygen therapy, which uses oxygen at high pressure to enhance tissue oxygenation and support healing, especially in cases of extensive necrosis. Along with the hyperbaric oxygen therapy, nutritional support has to be provided to the patient to ensure adequate intake of essential nutrients that support tissue repair and overall health management. In pre-radiation therapy, HBO is used as a preventive measure before the radiation therapy to reduce the risk of developing osteoradionecrosis, and it helps to improve the blood supply and oxygenation of the oral tissue that will be exposed to the radiation. In post-radiation therapy, by using the hyperbaric oxygen therapy. It is used in those patients who have developed osteoradionecrosis after radiation therapy, where it enhances the healing by improving the oxygen delivery to the affected area and thereby promoting repair and reducing the necrosis. So this was all about the osteoradionecrosis, its management. And if you like my video, please consider subscribing to my channel. And thank you. Bye bye. Have a nice day.